So disclaimers, I work for Kaiser, so I can't represent anyone and I don't endorse any company and no company endorses me. So get that slide out of the way. All right, just a friendly reminder, out of respect for patient privacy, I just ask that you kindly not take any photos of any patient-sensitive material and or share it online or wherever. Our agenda. So we're going to talk about who we are and what we do. That was really the reason why I agreed to give this talk. When Dr. Nguyen reached out to me, he said, hey, a lot of people in the community don't know what you guys do. And so I said, okay, I'll come out. We'll talk about it, and we're going to talk about the Kaiser system just really briefly. We're going to talk about the basic principles of orthognathic surgery, some of the more common dental facial deformities that we treat, a little bit on the orthodontic and surgical treatment planning. We'll talk a little bit about the surgical technique, some complications. I've had my fair share, some befores and afters. I think that's what you guys really want to see, right? Right. So try to stay awake because I have a lot of slides. I have 200 slides. I'm going to try to buzz through them so we can do the befores and afters at the end, okay? And then I'll take some questions. If someone can just give me like, let me know if I have when I have 15 minutes left, so that way I can kind of gauge how fast I need to go. All right, so Kaiser, what is it, right? It's probably one of the largest HMOs in the West Coast, right? You see the commercials, you hear the jingles, you know the motto, thrive, right? Kaiser as an entity is comprised of three separate entities, right? You have the Kaiser Foundation Health Plan, which is the insurance. You have the hospital system, which funds the hospital and all the hospital-based employees, like your nurses, your lab techs, and all that stuff. And then you have the Permanente Medical Group, which is the group that funds the physicians. So it's nice to sort of have this sort of checks and balances, between the three, among the three institutions, and it seems to work really well. Nationally, we have about 12 million members, 40 hospitals, about 600 plus medical offices across the nation. Majority of it is on the West Coast for sure, but we are trying to branch out further east. You can kind of see where all the local markets are. Majority of them are in Northern California and Southern California. I'm at Santa Clara, by the way. The maxillofacial division. Now, we're a regional service. So that means that we're not located at every medical center, we're only located at 3 in Northern California. Oakland, that was the first one that opened back in the early 90s. And a lot of you guys probably have worked with or heard of Felice Orion. She's the one that kind of started the program up in Oakland. And, it got busy, right? And so a lot of people from the South Bay needed surgeries and all of them couldn't get their surgeries at Oakland. So in 2005, we opened up two new branches, one in South Sacramento and one in Santa Clara. We're all the same. We all kind of operate the same, The only really difference is that Oakland and South Sacramento, their divisions are under head and neck surgery. We at Santa Clara are under plastic surgery. Now, Santa Clara maxillofacial surgery, that's the Santa Clara campus. We're a hospital-based practice, which means that, 2 to 3 days we're in the clinic, and then the other 2 or 3 days we're in the OR, sometimes more depending on our surgical volume. We do take call for facial trauma, and that's it. We do not take dental call. So you're probably wondering, well, who takes care of the dental infections and all that stuff? We have a gentleman's agreement with the ENT department. So if a patient comes in with an odontogenic infection, ENT will usually handle it. They'll do an incision and drainage, and then have the patient follow up with their dentist or oral surgeon to take the tooth out, right? And so we try not to kind of get involved because, we really don't want to kind of get involved in doing dental extractions and whatnot. Our clinic space, this is what our clinic room looks like. It's a decent size. I spend most of my time in the clinic kind of just talking, we kind of just basically do our consultations. We have 3 exam rooms that look like this. Consultations, the occasional small procedure, maybe like a biopsy or something like that, but most of the time we're just kind of spent talking, right? As you can see, we have some patient education materials in the back there, some skull models. We have our workstation, a blue curtain there, so we can take some photos. It's pretty basic. We have our own X-ray room where we have our CBCT machine. We have a 3D camera, dental scanner. So, we got all the equipment that we pretty much need fitting in our clinic space. Our ORs, we have two ORs. There's an ambulatory surgery OR, and then there's a main OR. We do most of our stuff in the ambulatory OR because we have a dedicated team there. That's my surgical tech over there, Olga. She's been with us since 2010, and she's awesome. That's me. So, so in the ambulatory surgery, we do mostly same-day surgery. This is like when people go home the same day. They can stay 23 hours. We do the smaller cases here, like the cysts and the small tumors and lesions, TMJ, small procedures like arthrocentesis. But we also do a lot of our facial trauma here, and we do all of our orthognathic surgery here because most of our orthognathic patients are able to go home either the same day or the next day. So we can admit them as a 23-hour stay, and it's still considered outpatient. The main OR is mainly where we do the bigger stuff. Now you're probably thinking, well, what can be possibly bigger than orthognathic surgery? Well, yeah, there's a lot of other stuff that we do. TMJ reconstruction, head and neck cancer, and a lot of stuff that's way beyond the scope of our talk today. And usually those patients are maybe a little bit more critically ill and or need more than 24-hour admission. Our staff, these are our maxillofacial surgeons. That's me. I joined Kaiser back in 2008, so I just celebrated my 15th work anniversary. Peter Bowie, he joined the year after I did, so he's been there for about 14 years. And our most recent hire, Dr. Young Kwan, he joined us just 2 months ago, so we're really excited to have him. And now you can finally put a face to a name when you can talk to him. We also have our own physician's assistant. Her name is Allison Stokes. She usually does all the first assisting in the OR. She sees a lot of our clinic patients and some of the new consultations as well. And then Dr. Cyril Prandarakulam, he's an orofacial pain, oral medicine physician. We hired him about 3 years ago. He sees all the complex facial pain stuff that you guys don't like to see. Well, none of us like to see, right? As well as a lot of the annoying sort of oral disease manifestations like lichen planus and stuff like that. God bless this guy. I'm so happy that we have him. Okay. All right, stop advancing. Let's see, you're over there. Okay. Okay. Now, we also have our dental assistants. Now, a lot of you have interfaced with our dental assistants. They're really the backbone of our clinic. Celesta, Jennifer, and Kat. I mean, they do a lot for us, and we simply can't function without them. They do patient care coordination, appointment scheduling, surgery scheduling, x-rays, dental scans, assisting in office-based procedures. And then finally, we have our Stanford surgery residents. They're plastic surgery residents, and they rotate on service with us. Usually there's a PGY3 and a PGY5 that rotate for 3 months at a stretch throughout the year. They take first call, and they round on our patients. God bless them, but it's really nice not to get called in the middle of the night to do a simple face laceration repair because we got our residents to handle all that. And they also assist in the OR. Now, this is probably the most important slide for a lot of you because a lot of you want to know, well, what exactly do we do? Do we do like wisdom teeth? Do we do this? Do we do that? And a lot of times we get referrals that unfortunately we have to cancel because, there's a lot of stuff that we're asked to do that we just simply don't do because of the Kaiser health plan policy, right? So what do? We do orthognathic surgery, right? We do maxillofacial trauma. We do surgical TMJ, right? Sleep apnea, mostly maxillomandibular advancement, alveolar cleft repair, benign head and neck pathology, like your tumors and your cysts and whatnot, maxillofacial resection and reconstruction, maxillofacial distraction. So it's a pretty good sort of variation there of the sort of the bigger stuff. We're also involved in a lot of the multidisciplinary clinics, craniofacial clinic, head and neck tumor board, as well as a local sleep apnea clinic. What we don't do, all right? Yeah, so these two pictures here pretty much summarize what we don't do, right? We don't do wisdom teeth. We don't do dental extractions. We don't do tori removal unless it's causing some kind of significant pathology, right? Bone grafting for dental implants, nada. All right. Implants, nada. All right. Insertion of tabs, don't even bother asking me because I will not do it. All right. Exposure and ligation of impacted teeth. Yeah, Ken will, yeah, sometimes, right? Management of dental trauma. So fractured teeth, avulsed teeth, we don't handle any of that. Oftentimes we'll have them say, we'll advise the patient to see an outside oral surgeon or dentist to take care of that. But Kaiser policy, we don't cover dental trauma. And then, of course, cosmetic surgery and cosmetic procedures, we don't do any of that either. Now, how do the referrals work? This is also probably important for us to know, right? So our number one, a patient must have Kaiser membership, right? So sometimes I get inquiries from outside dentists that say, hey, I got this patient, he doesn't have Kaiser insurance. How can you see him? He'll pay out of pocket. No, it doesn't work that way. You have to have a Kaiser health plan, right? So Kaiser membership, the referrals are usually generated through an online platform called eConsult. And it's usually, so these referrals are internally generated by the patient's PCP or maybe by a specialist like an ENT surgeon or a plastic surgeon that wants us to see a patient, right? If there's a request from an outside dentist, like if you wanted to send a patient, to see us, for whatever reason, the best way to do it is to send a letter with the patient. The patient will send that letter to their PCP. They can email it to their PCP and say, hey, my dentist says I have this problem and I need to see a maxillofacial surgeon. Can you please refer me? And the internist will go ahead and submit an eConsult. And this is what our eConsult page looks like. So, you have like the campus where you want to send the patient to, the department, and then we have all these problem reason codes. Like, so why, so has to fit within one of those problem reason codes in order to be able to send it to us. No. The internist will do this. Yeah. Patient does not have access to that. You can actually email our RDA. The RDA will usually call you to get all the records before we actually secure the appointment with the patient. Okay, so orthodontic surgery. Okay, we got a big talk here. I got like 200 slides, right? So I'm going to try to really buzz through a lot of this, and a lot of it is dry, and a lot of it's going to seem very elementary, especially for our orthodontists in the crowd. So and I apologize, but I feel like you kind of have to know some of the basics to understand why we do what we do. Now, orthodontic surgery makes up about a third of our practice. We have, and it almost always involves a close collaboration with the orthodontist. The orthodontist is typically the person that sees the patient first and will have will have that patient referred to us. The question comes up is orthodontic surgery covered by insurance? Yeah, it is, but it's more nuanced than that because Kaiser offers many different sort of tiers of health plans. And so if you go cheap and buy like the cheapest plan, you're going to have a really high copay. But still, it'll probably be cheaper than paying a surgeon on the outside like $50K to do a surgery like this, right? The orthodontics, unfortunately, is out of pocket for the patient, but it's still a deal for them. I mean, if you can get your surgery covered somewhat, then yeah, I mean, I think it's a great deal. We at Santa Clara, we average about 100 cases per year per surgeon. So if there's like 3 surgeons, that's probably like close to like 300 cases a year. More often than not, we do double jaw surgery than single jaw surgery. All right. We're going to talk about that in a little bit. All right. But more often than not, we do more double jaw cases than single jaw cases, and so it's important you remember the letters DJS, because you'll hear that word a lot sometimes online and stuff like that. A lot of patients use the word DJS. Hey, I'm thinking about having DJS. DJS stands for double jaw surgery. The age range, I mean, it's pretty wide. I mean, this used to be a surgery that we used to do like on adolescents and like young people. Our summers would always be booked because that's the time when young people could be off school and have time to recover. And then like during the fall and winter months, it'd be totally dead for us, right? I'd say in the last 10 years, it's like busy all the time. I mean, we have patients from the age of 15 all the way up to 65 plus. having surgery. And yes, there are people in their mid to late 60s, maybe even their 70s, that are getting double jaw surgery, like this gentleman here. And he did great, by the way. He did better than a lot of our younger people. So, now the goals of orthodontic surgery. This is important to know too. What are the goals of orthodontic surgery? It's the surgical correction of a dental facial deformity. And the reason why we want to correct the dental facial deformity is because we're trying to improve certain things that are caused by the dental facial deformity, namely malocclusions, speech, mastication, breathing, sleep apnea, right? Aesthetics, and I starred this. There are prerequisites for having orthodontic surgery. Number one, the patient has to be skeletally mature. All right. We're not going to do surgery on someone that's still growing. That's a big no-no, right? Now, for females, skeletal maturity is usually around 15 to 16 years of age. Males, probably 17 to 18. Sometimes for males, I'll kind of push it out a little bit later, How do we determine skeletal maturity? Well, our orthodontic colleagues like to use hand wrist x-rays. I like to use serial lateral cephs. You get a ceph like maybe every 6 months to a year, depending on the underlying issue. But like if it's somebody who has like a really prognathic mandible, you probably want to get a lateral ceph every year and kind of just superimpose them and kind of see, hey, has there been any change? Now these patients should have an orthodontic evaluation before they even come and see us. So yeah, on occasion you'll have a patient that comes in, never saw an orthodontist before. All they know is that, hey, I got this underbite and I need it fixed, right? And then you spend your time talking to them about the surgery, and then you say, okay, well, you need to see an orthodontist now. And what? I need to see an orthodontist for what, right? Well, orthodontics is like the most important part of this whole thing, right? So, most patients will need some form of orthodontic alignment before surgery and even after surgery. So this is also very important to sort of convey to the patient, right? Now, I got to spend a couple of minutes talking about challenges, all right? Challenges that I'm facing every day, I'd say in like the last 5 years, okay? We are dealing now with a crop of patients that we call the selfie generation, right? And these are the people, they're on one of the 3 social media platforms. I call it the Holy Trinity, right? Facebook, Instagram, TikTok, right? And they're just posting stuff about themselves, their face, their appearance. And I can't tell you how many times I have younger patients, coming in and asking me, will I look better? Is my appearance going to improve? Right? And it's getting a little bit much. It's getting a little bit much. I don't know if you guys feel it, but I feel it, right? Yeah, you're nodding, right? Yeah, right? Exactly, right? There are online forums too, Reddit, right? Oh my God, Reddit. Oh God, this kills me, right? But there on Reddit, there are several sort of subreddits or subforums, and there's one that's completely dedicated to jaw surgery. And there's a subreddit completely dedicated to Kaiser jaw surgery, right? And so this is like, people go on there and they just throw whatever, they have post pictures of themselves saying, do I need jaw surgery? And, they hear from like their peers, all of whom are non-medical, non-dental professionals, right? So they're getting all their information on there. But you can't really discount the aesthetic concern, okay? You got a guy like here, right? This gentleman here, he's a classic class 3 skeletal underbite. Society will look at this guy and say, dude, that guy looks mean as F, right? Look at him. He just looks intense. Even when he smiles, that's just not, he's not being, it just doesn't look nice, right? And that's that's a concern. It's sort of like this, this thing that we just kind of assign to these people, right? So you can kind of understand that a lot of these people have concerns that are legitimate. And then after surgery, he looks less intense. He's got a nicer smile, right? I mean, this is a guy that I could probably approach and not be afraid of, right? Yeah, right. On the other side of the spectrum, the person with the class 2, right? Deficient mandible. Society looks at these people and say, yeah, he's probably dumb, right? Because, when you look at like those like caricatures of like dumb people, they're always kind of like, right? Like the deficient chin, right? That's how we perceive people who have this sort of class 2 skeletal pattern, right? And so, yeah, that's a concern. It's a legitimate concern, and I have to pay attention to this, right? After surgery, not so much. She's looking pretty decent now, right? Now, there are some people out there, when they have their surgery, they're so happy with their results that they'll post their picture everywhere online. This gentleman was a patient of mine. When he came into my office, I was like, whoa, right? What am I going to do with this guy? Severe class 2 short mandible, right? And this was him after surgery. Yeah, right? Yeah. I mean, this picture, these before and after, it's like if you just Google it, it's there. It's like everywhere. In fact, a lot of my patients have seen this picture and they're like, I want that. Right. Yeah. On the other side of the spectrum, though, right, you got a patient like this who's got, the sort of long face, right? Gummy smile. And to me, I think she's got a nice result after surgery, right? I mean, that's like freaking model right there, right? And like for me, that was like my top 5 results, right? She hated it. She hated it. She hated that. She hated it because she could not adjust to the change. 5 years after the surgery, she called me and she said, I think I'm happy with the way I look. Yeah. But for 5 years, this ruined me. You can have hundreds and hundreds of excellent results. It's always that one result where a patient said I was disappointed and it just kills you, right? Right? Y'all feel me, right? Yeah, yeah. All right. So I guess the point I'm trying to make here is we have to manage expectations, right? We got to manage expectations, right? I always tell my patients, look, surgery is elective, even though it may be medically indicated, but it doesn't mean that you have to do it. You're not going to die if you don't do this surgery, okay? Unless you have sleep apnea. The main indication for surgery is to restore and improve your function, chewing, speech, breathing, all that stuff, right? Any aesthetic benefit from the surgery is secondary. It's what we call the proverbial cherry on top of the sundae, right? So aesthetic results are subjective, right? What looks good to you may not necessarily be what looks good to me and vice versa, right? So surgery may not improve your TMJ issues, right? So this is also a big rumor that we have to dispel, like that, oh yeah, I can do this surgery and improve my TMJ. Wrong. Surgery can make your TMJ worse, or maybe it may be unchanged, but we can't guarantee that surgery is going to make your TMJ better. So don't come in thinking that, their TMJ situation is going to be cured with jaw surgery. It's a long commitment, 2-year treatment timeline, right? The bulk of which is in orthodontics, right? The treatment begins and ends with orthodontia. You gotta commit. If you can't, don't do it, right? And no, you cannot speed up the treatment. Let me go back there. No, you cannot speed up the treatment, right? Why does it keep changing? Can't speed up the treatment. Now I got the picture of the Sistine Chapel here, right? Because if you remember, people were asking Michelangelo, when are you going to be done? And he said, I'll be done when I'm finished, right? So it's kind of the same thing, right? Okay, now the basics. We're going to go over some of the basics of like, orthodontic surgery, dental facial deformities, right? So dental facial deformities by definition, actually, let me go back. It's usually identified in childhood, or during or after puberty. By definition, it's an abnormal growth in one or both of the jaws in one or more planes. And the planes that we're talking about are like the sagittal plane, the vertical plane, and the horizontal plane. The growth can be excessive, it can be deficient, it could be asymmetric. It could be all of the above, right? And it almost always results in some type of malocclusion, and usually that malocclusion will be moderate or severe, okay? Speech issues, breathing issues, mastication, and of course, aesthetic. And then of course, patients can develop TMD as a result of their malocclusion. These are some of the common skeletal patterns that we look at. I'm not too crazy using this terminology, right? So you have the class 1, which is what we call like sort of the orthognathic skeletal pattern, class 2, what we call retrognathic skeletal pattern, and class 3, which is the prognathic skeletal pattern. Yeah, I'm not too crazy about this because you're when you're saying retrognathic in this situation in a class 2, you're talking about the relationship of the mandible to the maxilla. But some people might actually call a class 2 a maxillary prognathism, right? Or a class 3, they may not call it prognathic, they may say maxillary retrognathic. So I try not to use this terminology. I'll tell you what I use in a little bit here. Now, of course, the types of malocclusions. Now, this is very elementary, so I apologize, all right? Underbites, overbites, open bites, cross bites, right? All of these things can be the result of some kind of dentofacial deformity. And as you can see, these are, on the moderate to severe end, right? Now, you do have dental malocclusions and you have skeletal malocclusions, right? Dental malocclusions typically are mild or moderate, and usually they're due to some kind of intra or interarch discrepancy, and usually it can be treated with traditional orthodontics, right? That's like 95% of the orthodontic practice, right? On the other side of the spectrum, you have the skeletal malocclusions due to a dentofacial deformity. These are usually moderate or severe, usually due to some kind of skeletal jaw discrepancy, and usually the treatment for them kind of depends. There are non-surgical options, depending on how old the patient is. If they're kind of still growing, you can try growth modification. If they're sort of skeletal mature or have adult dentition, then you might want to think about camouflage orthodontics. But then you have the surgical option, which is surgical orthodontics and orthognathic surgery. Now, why do I have camouflage orthodontics and pre-surgical orthodontics highlighted? Because there are some people that don't know the difference, right? And so it's important that we have to tell them the difference, right? Now with growth modification, just really quickly, typically for moderate to severe skeletal discrepancies that are identified in childhood, kind of implemented in the prepubertal mixed dentition stage. A lot of you guys probably do some type of growth modification, right? Rapid palatal expansion is a form of growth modification. Headgear, right? That's sort of the one that we're more sort of commonly familiar with, right? The chin cup, right? The problem with those is that, kids are not going to be compliant with these things, right? And so, a lot of my orthodontic colleagues don't necessarily do the headgear anymore. Now, for the more severe cases, if they come and see me, I'm just going to tell them this: let them grow, let them grow, let them grow. Don't do anything, and then wait until you're skeletally mature and just do the jaw surgery, right? Just don't do anything for now, right? Now, orthodontic camouflage, a little bit more orthodontic camouflage. Basically, when a person has like the sort of full dentition, adult dentition, the purpose of the orthodontic camouflage is you're basically moving the teeth, but not really correcting the underlying skeletal problem. So you may be moving the teeth a little bit out of the basal bone just to kind of get them to contact a little bit better. You're kind of camouflaging the underlying skeletal issue. Sometimes it involves selective extractions like bicuspids to create space that allows you to retract the anterior dentition. A lot of times it involves using skeletal anchorage. And so, as you can see here, retracting these teeth, you see the mandibular incisors are sort of like lingually tipped. That's really not their sort of natural position, but it's passable. There are limitations with orthodontic camouflage, right? You can get satisfactory occlusion and all that stuff, but there may be some long-term stability concerns. The teeth may not be aligned with the basal bone. You may end up with some root resorption and periodontal compromise, especially if you're applying heavy orthodontic force. Sometimes it can be prone to relapse. Orthodontic, if the patient doesn't wear their retainers, if the patient is a class 3 and you treated them with camouflage orthodontics and then they hit puberty and then whoop, the jaw continues to grow, they're going to get skeletal relapse, right? It may not address underlying breathing issues because you're not changing the skeleton. And it may not address their skeletal concerns, like patients may still appear prognathic or retrognathic, right? Even though their bite may look awesome. So, here we have an example of some root resorption there, and this is sort of a side profile. You can kind of see, I mean, it's not terrible, but yeah, there's a little bit of excessive labial tipping of the maxillary incisors to close this underbite, and as a result, it resulted in this root resorption. All right, now here's a patient that saw me who class 2 skeletal pattern, and her main concern was really the sort of convexity of her facial profile. She's like, my chin is really weak, I snore, right? Yeah, she has all the makings of somebody who could have sleep apnea, right? But she had camouflage orthodontics. And what am I going to do with that? Like the orthodontist did a beautiful job, treated the bite. Hey, that's good. For me, I need some kind of overjet here. I need the orthodontist to create an overjet so I can really maximize that mandibular advancement. And now I can't do it, right? And so if I go back to the orthodontist and I call the orthodontist and say, hey, can you like undo everything that you just did? Right? It's usually not received very well, right? So I kind of have to, you know, do some surgical trickery to kind of achieve what I need to achieve, right? The same thing with this young lady, you know, class 3 skeletal pattern. Like she's clearly a surgical case. I mean, clearly. But when she was younger, she was treated with camouflage orthodontics. And then her mandible started to grow, right? And so she ends up with this. So now with this, what am I going to do with this, right? For me, it would have been helpful for the bottom teeth to have been pushed out. I could really maximize the sort of mandible setback or maxillary advancement, give her a nice aesthetic change. What am I going to do with this, right? Yeah. So we have orthodontic camouflage, but you know, the teeth can actually naturally try to camouflage themselves. We call it dental compensation, right? So a lot of these patients who come in who haven't had braces before, you know, you take this young lady, you know, to me, I was like, hey, she doesn't really look that bad. But then I looked inside her mouth and I was like, oh, yeah, she's got this sort of like camouflaged underbite, but it's actually a dental compensation. Sometimes the anterior teeth will naturally try to contact each other. The opposing teeth will naturally try to move towards each other. We call that dental compensation. And it masks or it compensates for the underlying skeletal discrepancy. So now this is very important, right? Because now when I talk to the orthodontist, this, right, is the crux of the orthodontic treatment, right? Crux of the orthodontic treatment. Because in pre-surgical orthodontics, right, we want them to decompensate the teeth. So pre-surgical orthodontics is the complete opposite of camouflage orthodontics, all right? Sometimes, you know, especially with an inexperienced orthodontist, Julia, you'll probably remember, right? You'll get some of these patients, right? They come in and you're like, the orthodontist kind of did camouflage orthodontics instead of sort of decompensating the teeth. And you're like, what WTF? Like, what am I going to do with this, right? Right? So very important that when you see these patients that, you know, you explain to them, hey, you know, you need to work with an orthodontist that's familiar with surgical cases, you know, an experienced orthodontist, all right? Because they will understand this concept, you know? So with pre-surgical orthodontics, you're aligning the teeth relative to the basal bone. You're decompensating the dentition. So you can see from this, she went to this. Now, this is something I can work with, you know, hey, all right, now we're talking business here. And so we have to tell the patient, as you go through pre-surgical orthodontics, the bite seemingly is getting worse, right? Because you're going from like a bite like this, and now all of a sudden the bottom teeth are being flared out. Oh my God, I have this bad underbite, right? Well, yeah, that actually is your true underbite. You know, it's just been hidden all this time, right? So now this young lady, she got her pre-surgical orthodontics. The orthodontist did a great job. I have something to work with. And bingo, you know, give her a nice surgical result. She's got a nice bite, you know, and she is happy. This young lady, you know, class 2, dental compensation. You can see those bottom teeth are kind of flared forward, right? So how am I going to advance that mandible if I don't have any room, right? So the orthodontist did some dental decompensation. Now I got a substantial overjet. She still needed a chin advancement too, you know. I mean, you know, just advancing the mandible alone was probably not going to improve all this. And so now here she is, and she's happy as a clam. All right. So now, all right, we got the basics down. We're going to talk about the initial consultation, right? So yeah, before the consultation, I like to have photos, x-rays, dental models, all that good stuff, right? This is what I often have to kind of think to myself, right? When I go and see a patient, right? Like my job is not to try to convince these patients to have jaw surgery, right? That's not my job, all right? That's their decision. They have to make that decision. My job is to kind of just determine whether or not these patients are candidates for surgery, right? Whether they're candidates for surgery. So I have to think to myself, where did that go? Right? Are the problems too severe to be most effectively managed with orthodontics and dentistry alone? That's what I have to kind of think to myself, right? And if the answer is yes, then yes, they are a candidate for surgery, right? So sometimes I'll walk into the room and I'll look at a patient. Is this a surgery candidate? Yeah, right. I mean, it's like no duh, right? Like I'll walk in and be like, yeah, okay, when do you want to do this? You know, right? I mean, there's no way anybody can treat this with camouflage orthodontics, right? I mean, come on, right? Yeah, this is a surgery candidate, right? So some of the initial questions that I like to ask when I see a patient, like what's their chief concern, the issues with their bite, speech, breathing. I'll ask about their orthodontic history. If you have your third molars removed, because for us, it's very important that the third molars are removed prior to surgery. Very important question, probably the most underdiagnosed medical condition, right? Sleep apnea. So I want to ask them if they have sleep apnea. Now, especially if I see a class 2 patient, that's probably the first question I'm going to ask them. Hey, man, do you snore, right? And if they do, if they answer yes to all the questions, do you snore? Do you fall asleep when you're driving? Blah, blah, blah. I'm ordering a sleep study on them first, right? TMJ history, right? Do they clench? Do they brux? Do they wear a night guard? These are things that I need to know, because if they have severe TMJ issues, we're not doing anything until you get that treated, right? Adolescent females, sometimes I'll ask them, when was the onset of their first menstrual period? Because sometimes in my mind, 2 years after their first menstrual period usually signifies the end of their skeletal growth, right? For adolescent males and females, I'll ask about any recent growth spurt. This. I'm seeing a lot of transgender patients in my office now. Now, unfortunately, none of them would sign off on letting me show their photos to you guys. And that's okay, maybe if we stop marginalizing them as a society, they'll probably be more, they'll be more permissive, right? But gender identification, there are a lot of patients out there, sometimes you'll have the female transitioning to a male, right? That wants to have a very strong appearance, chin appearance, right? And you have the male transitioning to a female that wants to have a softer profile, so these are things that I kind of have to pay attention to, right? And it's becoming more common. All right, so the clinical exam, just real quick. So when I examine them, frontal exam, I look at their frontal facial thirds. There should be equal thirds, top third, middle third, bottom third. If they're short in any of those horizontal thirds, then we call them brachycephalic. If they're excessive in any of those facial thirds, we call them dolichocephalic, right? Those are the two terms, right? Then I look at the face and I kind of divide it into fifths and looking for any sort of hard or soft tissue asymmetries. So this young lady, you can kind of see on the left sort of gonial angle, she kind of soft tissue mass over there. The maxillary vertical dimension. So you want to look at the incisal show at rest, right? Now, this young lady is showing a little bit more tooth at rest than maybe we'd want, right? Typically, you want to see about a couple of millimeters, so that tells me that she probably has some excessive maxillary vertical dimension, right? We look at the interlabial gap. In her case, at rest, yeah, that's about a 10, maybe 15 millimeter gap right there at rest, right? Now, this young lady down here, very little lip form, no teeth show, no interlabial gap. So that might suggest that she has maybe some maxillary vertical deficiency. And then we look at the incisal and gingival show when they're smiling, right? There it is, right there. Pretty gummy smile, right? Barely any teeth show, right? So now I'm kind of starting to think, okay, what are the issues here? Obviously, these two people have some kind of maxillary issue, but they're different. One has maxillary vertical excess, the other one has maxillary vertical deficiency, right? Lower lip redundancy. So, the class 2 patient will usually have a very short lower jaw. Their lips will generally be closed at repose, and the lower lip will generally be sort of outturned. And again, yeah, usually some type of AP deficiency. Midline discrepancies, so I kind of do an imaginary line down the middle, and I look at the dental midline, everything kind of relative to the facial midline. So the nasal tip, the maxillary dental midline, the mandibular dental midline, the chin midline, and then transverse cant. Is anybody familiar with transverse cant? No? Okay. So x-axis, y-axis, z-axis, right? So if my maxilla is like this and I'm rotated like this, what axis am I rotated on? Z-axis, right? The z-axis, because the z-axis goes out this way and I'm rotating like this, right? So here's a young lady, right? And she picked up, I honestly didn't notice it, right? But that was her initial complaint. Hey, my upper jaw's tilted, right? And I was like, really? So I in a lot of cases, you'll see it in the maxilla or the mandible, right? And it can be very subtle, like in her case, right? But if you look closely, you can kind of see she has a little bit more tooth show on this side than on this side, a little bit more gum show on this side than on this side, right? Kind of gives you a clue that, hey, something's off. So sometimes what I like to do is I like to put two lines, one intrapupillary line and one line going across the upper teeth. And if in here you can kind of see they're sort of diverging towards the patient's right, that kind of tells you that there's a tilt in the maxilla, right? Now, a maxillary cant is usually due to a mandibular cant, right? Because when the mandible grows asymmetrically, the maxilla will usually tend to follow, right? The maxilla normally doesn't cant on its own. It'll usually follow what the mandible is doing, all right? So she's got both a maxillary and a mandibular cant. Now, this is the type of terminology I like to use on the profile exam. This, so we look at the profile exam, we're really looking at the sagittal relationships of the top and bottom jaws, right? You got a class 1, class 2, class 3, right? But even like this terminology, I'm not crazy about using, right? Because you class 1, when you have a straight profile, right? Class 1, you say class 1, you'd think, oh, he's got a class 1 occlusion. But would you believe this guy actually has a class 3 malocclusion, right? Even though he has a straight profile, that's why he came to see me in the office, because he had a class 3. So the terminology I like to use is just straight profile, convex, concave. Simple as that. That's the terminology I use, all right? You look at the profile exam, and you also do the same thing with the horizontal thirds. You can see that this guy, kind of short bottom third there, But I also like to look at the sagittal relationship here. And, everybody kind of sees that the lower jaw is kind of short in the AP dimension. But what about the maxilla? Do you guys think the maxilla is short in the AP dimension? Why? What's the giveaway? Thank you, Dr. Gum. Yes, nasolabial angle, right? So yeah, the nasolabial angle. In this case, this guy's is quite obtuse, right? And we like that nasolabial angle to be like 90 degrees, maybe acute, right? So this is kind of like a giveaway that the upper jaw is a little bit further back from where it should be. What other condition do you think this guy might be suffering from? Thank you. All right. So whenever you see a guy like this in your office, that's the first question you should be asking. Hey, man, do you snore? All right. Okay. Now, microgenia, right? So sometimes that lower jaw deficiency, yeah, it's due to the mandible not growing, but sometimes it could be due to the anatomy of the chin. The chin sometimes can be just really flat, right? So you look at this this lady, she has the overjet is not much. It's not much, and these teeth have been fully decompensated. What we're dealing with here is, she's got basically a flat chin. We call it microgenia, right? So now with her surgery, I can pull her mandible like to Timbuktu. She's still going to look flat, right? So for a patient like this, you start thinking maybe I want to do in addition to a mandible surgery, maybe a chin genioplasty, right? You want to bring that chin forward, kind of get that nice little curve going, sexy time. That's what we're talking about here, right? Yeah. Now the intraoral exam, just real quick, I'm going to be looking at the crowding, spacing, camouflage, compensations, angles classification, overjet, or underbite, deep overbite, anterior open bite. We look at all that. Then finally, I'll look at the imaging, and for the imaging, I'm just a lateral ceph and pano guy. I don't need anything else, I just like it basic, all right? That's all I need. So, I'm going to look at the jaw size discrepancies, any skeletal asymmetries, condylar morphology, right? Kind of take a look at the condyles are well formed or not, right? And of course, airway, right? Airway, right? Got to look at that airway, right? The boring stuff, right? I actually had like 10 slides on lateral on cephalometrics, and I took it all out. So you're welcome. All right. Because honestly, I don't use cephalometrics anymore. All right. I don't. I don't. I may be shocking some of you out there. I don't. Right. So usually, we look at the cephalometrics. The cranial base. There are some values in the cranial base that are normally generally we consider like stable, right? And we compare the position of the maxilla and the mandible to those stable numbers in the cranial base. And then that kind of gives you an idea of whether or not there's a jaw size discrepancy in the maxilla, jaw size discrepancy in the mandible, right? There are drawbacks though, right? The numbers don't always accurately reflect the underlying skeletal problem, right? They don't always do that. The norms are based on averages of Caucasian patients. Okay. I don't only see Caucasian patients in my office, right? In fact, I probably see less Caucasian patients and more other patients, right? So my clinical assessment trumps my radiographic analysis. All right. We treat the patient, we don't treat the numbers. Now, this young lady right here, right? One of my first patients at Kaiser, right? She came to me and I looked at her and I was like, a lateral, I'm sorry, the cephalometric tracing would tell you that this young lady is maxillary deficient. Would you agree? Yeah. Mandible may be okay, right? So I was like, yeah, we're going to do a maxillary advancement on you. And she looked at me and she's like, Doc, I don't want my maxilla out that much. I want to look like a white person. And I was like, huh? Right? And then I kind of had to like think about it. And I was like, oh, well, yeah, okay. All right. Thank you for telling me, right? Because she's Korean, a lot of South Asian women or South Asian people in general, the maxilla is naturally concave, right? And they want to preserve that look. And I really didn't know about that until I moved out here to the Bay Area, right? She enlightened me to that, right? So we did her surgery. I did a mandible setback on her. And she was right. I mean, absolutely lovely, right? I was like, oh, okay, fine, yeah. I mean, look at that, right? She loved her result, All right, now, just some common dental facial patterns that I see, right? So you see the mandibular deficiency, the class 2, right? Now, typically this patient will usually have like a short lower jaw, outer turn lip. Sometimes they'll look like they have buck teeth, right? Because the maxilla relative to the mandible looks more prominent, right? All that good stuff. So when you see this patient, what's your surgical treatment plan? Mandible advancement? Who said mandible advancement? You're right. Right. Okay, yeah, chin reduction, right. Mandible advancement, right. Yeah. So with most mandible deficiencies, you can say, yeah, they need a mandible advancement. But what I tell my patient is, okay, you may need a mandible advancement, that's sure. But this patient, I looked at her upper arch and I looked at her lower arch. Which of these two arches is wider? The lower arch, right? The lower arch, right. So she's probably going to need a maxillary surgery too. And that maxillary surgery will be, got to widen her, right? So 70% of my class 2 mandible deficient patients usually end up being double jaw surgery. Because it's not just advancing the mandible, but I also have to expand the maxilla, right? So I have to tell them that I might have to do both jaws, right? Maxillary deficiency or mandibular excess, class 3. Now, this young man came into my office and he said, my lower jaw is too big and I want it set back, right? And I looked at him and I was like, okay, let's take an x-ray and see. And as you can see, his orthodontist tried to treat him with a little orthodontic camouflage there. Like that really flared those incisors out. Hey, but that's okay, But what do you think? Is he maxillary deficient or mandible excess? Maxillary deficient. Most underbites are actually because the maxilla didn't grow forward enough. It's not because the mandible didn't grow too big, And so I told him that, And this young lady, what do you think? Maxillary deficient, mandible excess? Well, who said both? Yeah, both, right, yeah. She's clearly going to be a double jaw surgery, right? Yeah. Okay. My favorite, long face growth patterns, right? Now these are great. Maxillary vertical excess with a mandibular deformity. Now this young lady, she didn't want me to, she wanted me to black out her eye. So total respect. Okay, fine. You agree? Long face, right? The long face patient usually will present with maxillary vertical excess, and with that a very gummy smile. And usually they'll have a narrow maxilla. Transversely, they'll be very narrow, right? Now it's interesting, right? Because when a patient has a transversely narrow maxilla, it'll usually try to compensate by growing vertically, right? That's what happens. It can't grow this way, so hey, I'm just going to grow this way, right? And so that's what happens. And so when it grows this way, it pushes the mandible down, right? And then the patients will usually end up having a very sort of steep mandibular plane. You really can't see it here, but she's got this sort of steep plane angle. You'll see it better on the x-ray. Bam, look at that. That's a long face, right? Is she going to need single jaw surgery or double jaw surgery? Double jaw surgery. That's right, man. That's right. You guys can do this. I can retire now. One of you guys could take over. I'm done, man. All right. Asymmetries. My favorites are asymmetries, because asymmetries, more often than not, it's the asymmetry will usually be because of asymmetric mandibular growth. Like I said before, when the mandible grows asymmetrically, the maxilla will sometimes follow, right? And that's what we see here. Now, what is the cause of the asymmetry? Typically, it's usually due to some kind of condylar issue, right? Because that's where the primary growth center is for the mandible, right? So you can have deficient growth in one condyle, and then everything will kind of grow towards the affected side, right? Or you can have excessive growth in the condyle, and everything will grow away from the affected side, right? So, you got to take an X-ray. What do you think her problem is? Is it condylar degeneration or condylar excess? Look at that condyle there. That's pretty short, right? Yeah, so that kind of everything just kind of grew towards the patient's right. And the mandible can't, maxillary can't, right? Chin has kind of pushed over to the right as well. Anterior open bite. These are, so yeah, you can have an anterior open bite with the long face, In most cases, the anterior open bite is usually because of a narrow maxilla, right? And then it kind of grows vertically. Like this is probably like one of the worst anterior opens because that's him. That's actually him biting down, right? like okay, dude. I'm like, we're gonna have fun with this one, right? Sometimes the anterior open bite can be due to some kind of condylar issue, right? When both condyles sort of resorb, like this patient has idiopathic condylar resorption, right? Ugh. When I hear that terminology, it's like, oh God, Usually with these patients, you don't want to sort of speed up their treatment, right? Because you got to wait for that condylar that resorption to kind of burn itself out. And in some severe cases, we do end up doing total joint replacement, but in most cases, I try not to do that. So yeah, you can see her, her condyles are just like really short, So with her, I kind of just, ordered, a nuclear bone scan, kind of saw how much condylar activity she has. And then I said, okay, if there's still some condylar activity, we'll wait like another year. And I just kind of kept pushing it off until I felt like she was stable enough to go through surgery. All right, so now you finished evaluating your patient, you're doing the cephalometrics and everything. How do you put all this together? When I talk to the orthodontist, like when I call Dr. Gum or when I call Dr. Shimizu or when I call Dr. Hane, and I'm like, all right, hey, what does this patient have? So like you want to state the malocclusion. Is it dental or skeletal? Is it a class 1, class 2, class 3 skeletal? Is there an anterior open bite? You identify the underlying skeletal deformity, 3 planes, right? AP excess deficiency, transverse excess deficiency, vertical excess deficiency, and then other issues, right? So now for this young lady here, she's got a class 2 skeletal malocclusion with an anterior open bite, secondary to maxillary AP deficiency, maxillary transverse deficiency, and mandibular AP deficiency, right? So that's kind of how I do the hierarchy, right? And when I write my letter to the orthodontist, that's how I list it, right? Okay, now my discussion with the patient, right? I talked to him about the goals of the surgery, the risk, benefits, indications, alternative treatments, treatment timeline, and that treatment timeline, like I said, 2 years or more. Pre-surgical orthodontics will usually take about 1 to 1.5 years. During this time, the patient should get their dental restorations and selective extractions done. They should have their wisdom teeth taken out at least 6 to 9 months before the actual jaw surgery. Then we do the surgery, then post-surgical orthodontist, which could be anywhere from 6 months to a year afterwards, all right? Any cosmetic dentistry, implants, replacing of missing teeth, typically you want to be done after their surgical and orthodontic treatment. Now, my proposed treatment plan, when I talk to patients, right? Like I said, 90% of my patients usually have double jaw surgery. Now, you've seen, right? I showed you all the common dentofacial patterns. You guys diagnose it yourself. Yeah, these guys need double jaw surgery, right? Most of them have an issue with both jaws. And I usually tell them, if there's a problem with one jaw, there's usually a problem with the other jaw. And we have to do double jaw surgery to fix it. That's exactly what I tell my patients, right? And when I tell my patients that they may be candidates for surgery, I usually tell them, when you're making your decision about whether or not you're having surgery, always assume you're going to be a double jaw surgery patient, always assume that, because I've made that mistake early in my career, right? Where I saw a patient and I say, yeah, you just need a mandible advancement, right? They go and they see the orthodontist, they get their pre-surgical orthodontics done, they come back, and then I look and I'm like, oh shit, Yeah, so remember when I told you you needed just bottom jaw surgery? Yeah, we're going to have to do top and bottom jaw surgery. And then that's when the patients freak out, right? When I change the treatment plan on them, you know? So right from the beginning, I'm going to tell them, yeah, you know what? You might be a double jaw surgery candidate. That might change, but just get ready to accept that that's what you might be. All right. The recovery is about the same, whether or not it's a double jaw versus a single jaw. So, most patients usually don't care. They're just like, well, I'm going to be out. So you might as well do whatever you need to do to me. Right. So, okay. Risks with surgery, the typical bleeding, swelling, bruising, infection, right? This is what I tell my patients. The big one, everybody's at numbness. Oh my God, am I gonna be numb for the rest of my life? Yeah, maybe, I hate to be blunt, but yeah, maybe. The literature reports anywhere like 30 to 80% chance of like long-term numbness. That's such a wide range. So, a lot of, you guys, a lot of your patients are engineers, right? They work in absolutes. A lot of my patients are engineers. They're always asking me like, what is the percentage of numbness? And dude, I don't know. You're gonna be numb. The recovery, it might come back, it might not. So, but what I do tell them is that it may be temporary, permanent. Usually the numbness does not impair other meaningful functions like speech, taste, kissing, all those things. When I say that, they're all, oh, okay, yeah, okay, cool, yeah, all right. No, I don't really care about numbness anymore. We talk about TMJD, how it could get worse with jaw surgery. Intraoperatively, there are things that we could experience like a bad split. We'll talk about that in a little bit. Dental trauma. Postoperatively, you can have orthodontic and or skeletal relapse, a bone non-union, or a persistent malocclusion. And then that may need a revision surgery. And then, of course, undesired facial aesthetics. And again, that's subjective, right? So, all right, after the consultation, I'll mail the orthodontist a treatment letter. Patient starts orthodontic treatment. The orthodontist will notify me when the patient's close to being ready for surgery. Typically, I'll ask the orthodontist to give me like a 3 to 4 months heads up because we are severely backlogged at Kaiser. At that point, I'll schedule a progress visit with the patient. And then if they're near ready, I'll put them on the surgery schedule. Now, fast forward 8 to 12 months later, patient returns with progress models. I'll look at the progress models. If the desired occlusion doesn't have to be perfect, but it has to be close, right? Looking for good interarch coordination. If there's a maxillary transverse width discrepancy, I might have to do a maxillary segmentation. We're going to talk about that in a little bit. And then get them on the surgery schedule. And then the orthodontist will have a pre-surgery checklist. Wisdom teeth, make sure they were removed 9 to 12 months ago. Molars banded, surgical wire inserted 4 to 6 weeks before surgery. Surgical hooks usually placed 1 to 2 weeks before surgery. You don't want to place them too early because the patient will just get super annoyed with those hooks digging into their lips, right? Now, why do we want the molars banded? This is a patient that I had while we were doing surgery. Can you guys see it? Can you see it? Can you see it? All right, for those who don't see it, right? You see that molar up there? Where's his bracket? Yeah, that happened. That happened. Yeah. I had to get a laryngoscope and fish it out because he could have aspirated on that. This was during surgery. Yeah. So yeah, sometimes I do get resistance from the orthodontist, like, hey, yeah, do you really need to band the molars? Yeah, like this is what I need, man, because this is what could happen. Molar brackets can pop off real easily, especially like when we're yanking on the jaws and stuff like that, So yeah, this is really important, right? Now, types of osteotomies, okay? We're getting into the good stuff, guys, all right? So stay with me, okay? All right. The workhorse for a maxilla is the Le Fort 1 osteotomy, right? It basically involves like a sort of just a horizontal bone cut across the maxilla. And with that, you can move the maxilla forward, backward, side to side, up and down. Very versatile. So you can kind of see here, this patient, you can use the maxilla and kind of bring it forward. Now, when the patient has a transverse width discrepancy, right? If their maxillary transverse, if it's narrow, I might have to end up doing what I call a segmental Le Fort. Now, there are 2 types of segmental Le Forts. There's a 2-piece and a 3-piece, right? So a 2-piece Le Fort is when they have a pure sort of maxillary transversely narrow maxilla. I'll basically kind of do a midline split, right? And so you're basically dividing the maxilla into 2 pieces, a 2-piece Le Fort, right? And then that enables me to expand the maxilla like that, right? Three-piece Lefort. Now, the three-piece Lefort is more versatile, and I tend to do that more often, right? So in addition to having maxillary transverse deficiency, sometimes you can have a patient like this who has this sort of biplanar sort of occlusal plane. They have like a step in the maxillary occlusal plane, right? And that's really difficult for any orthodontist, almost impossible for somebody to treat that. So I might have to divide the jaw into three parts, right? So I take the jaw and I kind of make these interdental cuts between the laterals and the canines, and then I can basically move that anterior incisal segment into a better position. I can kind of create better leveling, better alignment. So this is called a three-piece Lefort, and that's what it would look like, right? Now, a Sarpi, I added this last minute. I just thought it was just worth, So yeah, we do the two-piece, the three-piece to kind of expand the maxilla, but where does a Sarpi come into play? I would only ever consider, and by the way, Sarpi is surgically assisted rapid palatal expansion, right? So it's basically just a rapid palatal expansion, but you do it in a mature patient, you have to basically do the Lefort cut and all that stuff because when they're adults, the palatal suture is fused, right? So when you have a severely narrow maxilla with a lot of crowd, if I have to expand that maxilla by more than 10 millimeters, then I might as well just do a Sarpi instead, right? And if I do that Sarpi, again, you kind of do all the bone cuts, you have the palatal expander in there, then that basically means the patient's going to have a two-stage surgery. So stage one, Sarpi, then orthodontic alignment, and then stage two, orthognathic surgery to treat the bite problem, okay? So, yeah. So here she is, then the Sarpi, you got that's what you want to see, right? Then of course the orthodontist is going to fix that, right? And then now she's ready for stage two surgery, right? Okay. All right, mandible surgery. Now there's only really one mandible cut that I do. It's called the sagittal split osteotomy, SSRO or BSSO. Basically, it's a cut that allows us to split the mandible into a condylar segment and a dentate segment. So this allows me to move the mandible forward or backward, any which way I want to, all the while maintaining bone contact between the two segments here, okay? So yeah, you can use it to telescope the mandible forward. You can even use it for a mandible setback. Genioplasty, you can do a genioplasty for a variety of reasons. You can do it to bring the chin forward. Oh, come on, man, what's going on here? Oh, you know what? Anytime there's a pop-up, it prevents me from advancing.
We'll be done with your pop-up momentarily.
Okay.
We're just doing the poll that we announced at the top of the show.
Oh, okay, they're doing a poll, so that's why. Okay.
It'll just take a moment.
Okay. All right. Okay, there we go. Okay, yeah. So you can do a mandible, you can do a chin advancement. You can use a genioplasty to reduce a vertical chin excess, or you can do a genioplasty to augment the chin, right? Many different reasons to do a genioplasty, right? Now, my pre-surgical treatment planning, the goals of the treatment planning, right? You want to determine the post-surgical occlusion, and kind of working backwards, right? You determine the post-surgical occlusion, and then you kind of work backwards and think about whether or not I can get to that occlusion using single jaw surgery or dual jaw surgery, right? And for me, determining that, I have to kind of determine what's going to give me the most stable surgical result, right? Stability, function, form, right? When I determine the moves, I have to determine if these moves are going to be stable. And then the end point of the surgical treatment planning is we have to fabricate surgical guides, right? Because we need these guides during the surgery to help us determine how to position those jaws. I don't want to be standing there having this completely mobilized jaw and going, yeah, it looks good right there. No, we need surgical guides to tell us where to put those jaws, right? So typically we'll start with a digitized lateral ceph, looking at the hard and soft tissue changes after your proposed movement. You superimpose that ceph on the patient's photo, and then you kind of do your simulated movements, kind of see what it looks like, and then that kind of tells you how many millimeters you want to move the jaws forward or backwards. And once you're satisfied with that, you can kind of go on and start making your splints. Now, back in the day, Julia can attest to this. We You know, we're still using that lab, but not for that anymore, by the way. Yeah. So we have a lab in Kaiser, right? And so many a day after work and on the weekends, we did model surgery, right? So the orthodontist would give you the final surgical models. You'd mount them on an articulator. You make all your little marks. Then you look at, you know, your mock-up from your predictive tracing and you know, you kind of move the models into their new position. And then after all that is done, then you make the surgical guides. And it was basically acrylic and monomer. You'd mix it, form it on the articulator, wait for it to set, all that, you know. God, very time intensive, and it sucked, right? So yeah, the end point of doing all that was making your surgical splints. Now, typically for double jaw surgery, you make an intermediate splint and a final splint. You know, the intermediate splint is basically the splint for moving whichever jaw you're going to start off with, right? That jaw relative to the unmoved jaw. And then the final splint is the for the jaw that's moved secondarily. These days, everything's done virtually, 3D virtual planning. So now I don't even get dental models or anything. I just get a CBCT of the face, send it to this modeling company, and then I have like a 5-minute, 10-minute web session with this treatment planning engineer located in Colorado. And I'll say, I want the upper jaw moved forward 10 millimeters, and I want the lower jaw moved back 10 millimeters, and he'll do it for me. Yep, that looks good. All right. And then he makes the splints. I mean, it's great, you know, and it's highly accurate. You know, I can kind of see what the osteotomies are going to look like. I can kind of see whether it's going to be stable, if there's any sort of bony interferences. At the end, they'll email me a PDF with my proposed plan. So usually it'll look like something like this, where you have the initial presentation, the intermediate steps. For me, I always start with bottom jaw first. So bottom jaw surgery, what the bottom jaw is going to look like in its new position relative to the unmoved maxilla, and then the maxilla in its new position. And then, yeah, this patient's getting a chin. And then they'll also send me my calculated movements. They'll also send me a occlusal color map. Anywhere where it's colored usually means that there's high contact. And so I can do some occlusal equilibration before I actually do the surgery. They'll send me the actual splints. This is what the splints will look like. So you have your intermediate splint and your final splint. And if I'm doing a chin, I can get chin guides made. So I don't even, you know, so it's like IKEA furniture. You just boom, you know, just there, you know. Anybody can do it, you know, anybody, right? All right, the big day, surgery. Let's move on. So intra-op considerations. You know, our patients need to be nasally intubated. Why? Because we're going to be working inside the mouth and we're going to be banding them shut at the end of the surgery. So can't have a tube inside the mouth, right? They get a head wrap to secure the tube, and then the tube is stitched to the nose. So that way, and the anesthesiologists love working with us, you know, because I don't think there's any other service in the hospital that cares so much about the airway as much as we do, right? Right, Julia? Yeah. I mean, they love working with us because when they see us doing this, they're like, oh my God, that's awesome, you know? We put a throat pack in the hypopharynx to prevent any secretions or, you know, prevent the risk of any aspiration of anything. Then we'll locally infiltrate the surgical sites with anesthetic, betadine prep, and sort of towel them out, and then we're ready to go. Armamentarium. So this is what our typical armamentarium looks like. We've got a bunch of retractors, the mallet, I call it the hammer of Thor, and then my chisels, you know, all that good stuff. It's really not a lot, you know. That's what we and that's us getting ready to go. So that's me. That's my first assistant, Allison. That's the PA that I talked about. And then this is one of our surgical techs. His name is Seth, you know. So just the three of us, man, in the OR, just chilling, you know, doing our thing. Got the surgical guides ready, you know. So this is our intermediate splint, our final splint, our chin guides, all that at the ready. Now, the sequence, like I just said before, I like to start with mandible osteotomies first. Then I do the maxillary osteotomy. Then I do the genioplasty. That's the very last thing. Then we close the incisions, put them in MMF. By the way, MMF means maxillomandibular fixation, so we rubber band them shut. Now the sagittal osteotomy, right? So you know, quick review. So basically, we want to make our intraoral incision and expose the mandible both on the medial aspect of the ramus and on the lateral aspect. We then start off with making our medial bone cut right above the inferior alveolar nerve. And then we carry that cut down sagittally, hence the name sagittal osteotomy, usually to the first or second molar. And I'm sorry, this picture, we tried getting a shot, but it was just really hard. And then we make our inferior border cut and body cut. Right there. Okay. Then the chisels, right? We break out the chisels. We put the chisels into the sagittal cut and tap, 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 tap. And that's what we're doing here. And actually, if you look closer, you can kind of see a little separation there, right? That's what you want to see, little separation there, right? And then we put the Smith spreader in there. That Smith spreader will complete the split, right? Now, one thing, just a little thing I want to show you, right? So yeah, you need to see a little curve over here, right? That little curve means that the split's happening along the lingual cortex of the mandible, because that's where the cortex is thin and it'll propagate much easier. If this is too straight, that means it's trying to split along the inferior border of the mandible. Then you're gonna have some fun, man, because that split can go any which way, So that inferior border cut is probably the most critical cut because you want to really engage the lingual border, the lingual cortex. Now I like to identify the nerve, right? So the nerve should be riding along the dentate segment. But sometimes when you do the split, it'll get stuck to the condylar segment, and then you have to kind of fish it out, right? And kind of get it nice and loose, right? So that's the nerve right there, right? In all its glory. That's the inferior alveolar nerve, right? Then we put the patient into fixation, right? We wire we put the intermediate splint in, we wire them shut, right? And now we're ready to plate. So what we do first is you have to take the condyle and you have to seat it into the posterior superior most part of the fossa, right? Because that's the normal position, right? So usually I'll have my assistant kind of hold it there while I put the plate and I rigidly fixate it. So that's how we're sort of holding that, seating that condylar segment there. And then we plate it, right? And then we're done with the mandible. Then we do the maxilla, right? So the maxilla, we make our transmucosal incision. Yeah, we expose the maxilla, right? What's that guy right there? Louder. Nerve, right? I heard nerve. Yeah. That's V2, cranial, the trigeminal nerve, the second branch, right? The maxillary nerve, right? So that's the nerve that supplies all the feeling to the cheeks and the lateral part of the nose and all that stuff, right? So you wanna dissect all the way up to the nerve, up the piriform rim, up the lateral buttress, because you're gonna make your cut all across here, right? Then we do our horizontal osteotomy, right? Every surgeon's different. I usually start from laterally from the lateral buttress, and kind of work my way towards the nasal cavity. Some people work the opposite way. Here's a video. Oh, there's no sound. Where's the sound? Oh no, you got to hear the sound. Oh man, they're probably hearing it online. Yeah, I'm sorry, guys. Oh shoot.
We're actually not hearing it either.
Oh really?
Yeah.
Oh no. Okay. Let me see. I got to get that sound, man. All right, fine, whatever. Yeah, I can't. All right. Now, if I'm doing a three-piece Lefort, right? I have to make my intradental cut, so that comes next, right? So that's what I'm doing here. I kind of do it between the lateral and the canine, and then we do our detachments from the buttresses, right? The separation. So we drive the chisel through the lateral buttress, and then we do it through the medial buttress. That laser pointer is like dying right there. So that's what that looks like. Now, you're doing a good job when you start seeing that separation right there, right? I mean, it's like, yeah, okay, it's going the way you want it to go, right? And then the nasoseptal separation. So there's this vertical articulation, the nasal septum, right? So you want to separate that. So that's what we do there, right? And then the pterygoid maxillary separation. So we drive a chisel between the maxilla and the pterygoid plate. This is probably the most sphincter tightening part of the surgery, right? Right? Because what's hanging out over here? Just minding his own business. the maxillary artery, right? Yeah, you don't want to mess with that guy, that's bad news, right? So that's what I'm doing here, so I'm driving the chisel right behind, right there. And then I have my finger behind the hamulus because I want to feel the end of the osteotome right by the ham. When I feel it by the hamulus, then I know, okay, that's where I need to stop. Okay. So I've torn many a glove doing that. Yeah. All right. Oh man, I wish I had the sound, but okay, here we go. Down fracture. Yeah. Right. Yeah, so good. So I mean, you should hear the sound. It's like crack, like uh yeah, I mean it's I mean, yeah. So that's the bloodiest part of the surgery. So typically, we tell the anesthesiologist to drive the blood pressure down because it can get really bloody there. Yeah, it can, yeah. My blood pressure, yeah, no, the patient's blood pressure. Yeah, give me something too while you're at it, right? Yeah. Now here's the maxillary artery. That's what we're the descending palatine artery. I like to, when I have the maxilla completely separated, I need to look for that guy. Okay. And there he is, right there. That guy's the bane of my existence, right? He's a branch of the maxillary artery, and he passes right through the back of the maxilla. If that guy gets severed, I mean, just blood everywhere, right? A lot of times it's prone to developing an aneurysm after surgery. So for me personally, this is not every surgery. For me personally, I just like to clip that guy, like right when I see it. So I'll tie a ligature around it, so that way I never have to worry about it. Because patients are going to have a bloody nose after surgery, and sometimes the bloody nose can be profuse. But I don't want to be sitting there thinking whether or not it's because this guy is burst open. I want to go to bed at night knowing, okay, yeah, I tied him off so that it's not an arterial bleed, right? So that's why I tie that off. And then we mobilize the maxilla. So we apply row disimpaction forceps on the maxilla, and then we just start pulling it, right? So my residents usually have fun doing that, so they'll just kind of crank the maxilla back and forth to really mobilize it. And then if I'm doing a three-piece, we'll complete the segmentation. So the previous few slides we did the intradental cuts. Now I'm going to connect them to these paramedian cuts across the palate, like that. And then if I'm doing a three-piece, we got to distract it, right? We got to expand it. So typically I'll have them tie a wire ligature around the molars, and then it's like a tug of war. So my assistant and I will kind of stretch it out transversely. And then we put a splint in there and we wire it in. Then we trim, seat the maxilla, plate the maxilla, and then we're done. Oh yeah, alar cinch. So yeah, you have to do this. So anytime you move the maxilla, the nasal, the ala is going to flare. The nostrils are going to flare out, right? So I usually like to tie a little stitch under the nostril. That's what I'm doing right there. So you kind of see I'm tugging on the sutures, and you can kind of see the nostrils are kind of just pinching in, right? So then I know that, yeah, I've got the nasalis muscle in there. If I don't do that, then this is what's going to happen, right? So this was her before surgery, and this was her after surgery, and she was really mad at me. So, okay, yeah. Then maxillomandibular fixation. Then we put them in rubber bands, right? And then off to recovery they go. Ice packs on the face, clear liquid diet on the first day. Usually we'll have a feeding kit for them at the bedside, and then we advance them to full liquids on the first day. Nasal sprays for congestion, and we usually always have wire cutters at the bedside in case they can't breathe, right? So then the nurses know to cut the bands off just in case. Doesn't happen all too often. Common post-op findings: they're going to be numb in the face, nosebleeds, oral secretions, sore throat, usually because of the ET tube, and edema. Right? Yeah. How long is the surgery? So when we first started out, a double jaw surgery would take us like 5-6 hours. Yeah, sometimes now a double jaw surgery will take me 2 or 3 hours. I mean, but that it's not because I'm not bragging. It's just that I think with the technology and everything that we have at our fingertips now, I mean, like it's just easier. It's just easier. Yeah, 2 or 3 hours for double jaw surgery. So we usually end up doing 2 double jaws a day. Yeah.
I can attest that's a true photo.
Yeah. That second photo was probably like 2 or 3 days post.
No,
One day. Yeah. And usually edema will peak on day 3. Like that's usually the day that they'll feel their worst. That's the day that most patients will freak out. Maybe sometimes they'll even cut themselves out of their rubber bands on that day, you know? So yeah. So criteria for discharge, you know, they need to drink a minimum of 200 cc's. They need to ambulate with maybe some assistance, manage their pain manage with their pain meds, and then no difficulty with urinating. Yeah. A lot of them, you know, a lot of them are numb. So, you know, you think that this is a painful surgery, but their pain requirements are actually not a lot, you know, like because they're pretty numb in the face. So the numbness actually kind of helps, right? So most patients actually can subsist just on ibuprofen and Tylenol, you know? So we try to get away from the narcotics as much as possible. Activities, you know, I usually tell them limited activity between weeks 1 and week 6, you know, gym exercise they can do after 6 weeks, contact sports maybe after 12 weeks. Diet, it's totally a total of 6 weeks of no chewing. Bandage shut for the first week. So then during that first week, they're on a liquid diet, right? Then after the first week, I'll take the bands off, and then at that point they can advance to a pureed diet, like pureed non-chew, right? After 6 weeks, once we feel like things are healed sufficiently, then they can kind of do a soft chew diet, and then slowly advance to a firmer diet as tolerated. Follow-up appointments, you know, I'll see him at week 1. Usually that's when we take the elastics off. If there's a segmental effort, we'll keep the splint in for a total of 6 weeks. At 3 weeks, I'll start jaw stretching therapy to get them to kind of open a little bit more. 6 weeks, you know, we start on a soft chew diet. At that point, they can go back and see their orthodontist and resume post-surgical orthodontic treatment. At that point, I tell them, okay, I'm kind of stepping back into the crowd and your orthodontist is going to start taking over. So your orthodontist is going to be calling the shots, but I'm still going to be following along with you. And I'll usually follow them up to about 6 to 12 months afterwards. Complications, you know, yeah. So the big ones: hemorrhage, bad split, infection, hardware failure, non-union, relapse. This is probably a buccal plate fracture. So this is what happens when you don't make that inferior border cut deep enough. And then the split kind of goes along the inferior border, and then it decides to go up the buccal plate like this, and then the condyle break, like everything. So this happened to me, God, this is like not too long ago, right? And so you have one of two options at this point. Option 1, pack it up, pack it in, get the hell out of there, tell the patient what happened, let it heal, and then maybe try it again in about 6 months. Option 2, try to be a hero and salvage what you can and just move forward with the surgery. So option 2, yeah, right. So I mean, that's yeah, I just plated every little part that I could, and I went ahead and I did this, finished the surgery, you know, by God's grace. I don't know. This guy came in 6 weeks after surgery to the ER, profuse nosebleed, right? And so I saw that, I was like, oh crap, wait, I clipped the arteries, right? This shouldn't happen, right? So I asked the ER attending to get a CTA, a CT angiogram. We got the CT angiogram. Can you guys see anything there? This is the this is the maxillary artery on all the branches of the maxillary artery. That's an aneurysm in the maxillary artery. So way before the descending palatine artery branches off in the main trunk of the maxillary artery, there was a bleed, right? I don't know how it happened. It's a really freakish thing. We actually got this published, by the way, because it was so rare. So anyway, we saw this. We're like, okay, what do you do at this point? So you pack the nose, and then you send them to interventional radiology, and they will coil it. They'll actually do the rotor-rooter thing. They'll go through the groin, you know, go up through the vessel, and then put a coil in there to prevent for bleeding. So post coiling angiogram, beautiful. No aneurysm anymore. Gone. Bleeding stopped. So yeah, that can happen. Pretty rare. Relapse. So there's orthodontic and surgical relapse. You know, honestly, orthodontic relapse is like, you know, they stop wearing the retainers, they're going to relapse, right? The teeth are just going to start shifting, right? But there's surgical relapse, you know, like surgical relapse will usually happen because either the move was too extreme or the soft tissues were too tight and they kind of wanted to push the jaw back into its like previous position. So this patient, she was a class 2. That was before surgery. That was right after surgery. And this was 3 months after surgery, her overbite started developing again, you know? So at this point, you know, you pray that maybe the orthodontist can bail you out, right? Like, please. But sometimes if it's a little bit too severe, you might be looking at a revision surgery, right? Non-union. Oh, I love this one. This one is a doozy, right? So this patient had mandible advancement surgery, right? Everything went well. I was like, hey man, cool, awesome, right? And then I got her post-op x-ray. I was like, yeah, okay, what the hell is this? See that like dark line right there? Yeah, I don't see it over here, right? The split went through the entire lingual plate, from top to bottom, So basically she split sort of cross-sectionally as opposed to sagittally. And I didn't even see it intraoperatively, like stupid me, right? So I was like, okay, the midlines are still intact. I'm just going to keep her on a soft no-chew diet for a longer period of time, and we'll just see what happens. But then about a few weeks later, about 6 weeks later, she's like, hey, my jaw's kind of moving to the side and it's like hurting, And so I got another Panorex, and as you can see, like that gap kind of widened a little bit, so it started to distract apart, right? Midlines are off now, right? Midlines are off. She's deviating away from the affected side there, right? So I was like, oh crap. So at this point, she's bought herself a revision surgery, right? So I got to fix that, right? So you have that unpleasant conversation with her. Hey, so I got to take bone from your hip and I got to put it in there. And yeah, so that's what we did. And as a result, I also ended up having to take out that second molar because the second molar was right in the line of the, yeah. So I do extractions. Yes, I do. Yeah. And so that's what I did. So I put a titanium plate there to kind of really give her some really good rigid fixation. And then I just packed a lot of iliac crest bone. So that was her like a week after surgery. And then this was her about a few weeks later. Kind of healed in very nicely. And midlines were still intact. And I think she eventually went on to get an implant, not by me, though. All right. Cases. All right. Softball. What do you think she needs? She needs orthodontic surgery, right? All right. Yeah. Okay. I guess more specifically, maxillary mandible, both. Mandible, you're right. She just had a mandible surgery, and that was her result there. So, maxilla fully formed, mandible a little bit on the bigger side. You just set it back, but that little setback could make a world of difference. I mean, that's beautiful, beautiful young girl. Nice facial balance, right? All right. This lady, we saw her before. So maxillary and mandible surgery, right? So that was her after. Beautiful occlusion. Nice, right? Beautiful, right? Oh yeah, this one's a dude. What about this guy? Yeah, that's a nice one, right? Look at that. I mean, look at that mandible there, man. Woo, right? I mean, we're talking real concave there, right? Yeah. So, a lot of these patients, they stop following up after a while, and sometimes I can never get pictures of them where they're completely out of braces, So he's a 2-jaw surgery. So we advanced his maxilla forward, set his mandible back. The maxilla was a 3-piece, actually. You have to actually, yeah. And yeah, comparison there. Pretty nice change. Our friend, long face, right? Yeah. So we said, what do we say? Maxillary and mandible surgery, right? There's segmental Lefort, you guys think? Yeah, right. So she had a 3-piece Lefort. We impacted the maxilla, brought it forward. I forgot what we did. Yeah, we set the mandible back, and we also did a chin reduction on her. Right? So the chin reduction, because that she just had a very steep vertical chin. So I basically cut out like a 5mm strip and then reseated the chin bone, Yeah. Our other guy with the big anterior open bite. So what do you think he needs? Maxilla and mandible? Yeah. Segmental Lefort? Yeah. Yeah. So you're right. He had a 3-piece Lefort. Yeah. Look at that. 3-piece Lefort, mandible setback. Close that on. So, all right. Our fair lady over here. Sort of long face, right? Sort of like she actually has rheumatoid arthritis. So she had progressive condylar resorption, developed an anterior open bite. Is her maxilla narrow? Yeah. So 3-piece Lefort, you think? Yeah. Mandible advancement, chin advancement, you think? Yeah, so, yeah, okay. You're right. Yeah. So you got she got what we call trimaxillary surgery, right? Upper jaw, lower jaw, chin. We call it trimax. So that was her before and after profile. Almost like a different person, right? Yeah, yeah, yeah. Our microgenia patient, right? So we already know a mandible advancement and chin, right? She also had maxillary surgery, by the way. Yeah, I brought her maxilla forward just a little bit. So that was her after surgery. Yeah, yeah, nice bite and everything. So you can kind of see there. That's my chin, right? Very happy. It kind of looks younger too, right? Like it kind of like rejuvenated her, right? Yeah. My gal, asymmetry gal, right? So what are we doing with her? Everything, everything, yeah, yeah, everything, right? So that's everything. Yeah, she had everything done. Yeah. So what did we do? We did a maxilla. I think we did a three-piece on her. I can't remember. We did a mandible. I don't think we had to do a chin because everything kind of leveled out really nicely. But you can see like from her frontal, I mean her PA cephs, nicely aligned. Profile looks good, but really it's the frontal where you see the biggest change, right? And then finally, oh yeah, one of my favorites. Okay, so here's a patient, right? She was treated with, yeah, I mean, kind of class two-ish, right? But not much of an overjet for me to work with, right? Uh, Prominent maxilla, you know, and you can kind of see here. What are these guys here? They're tooth roots, right? What do you think what do you think the orthodontist is trying to do here? Yeah, camouflage, right? So you brought the roots out, right? Yeah. Yeah. So they were trying, to, bring ththose maxillary incisors back to close that overbite. And now it's my problem, right? I gotta work with this. So her main concern was, yeah, the gummy smile and just kind of like the narrow nose and like, the difficulty breathing and just like the excessive interlabial gap. She wanted it all fixed, right? So I was like, all right, let me see what I'm going to do. So, what did I do? Yeah, I did a maxillary setback on her. Yeah, and it's not very traditional to do a maxillary setback. Maxillary setbacks are really hard. They're really hard because when you set the maxillary when you try to set the maxilla back, there's a major structure back there. Does anybody know what it is that gets in the way? The pterygoid plates, right? And what's behind the pterygoid plates? Big red and big blue, right? The carotid artery, the jugular vein, right? So yeah, I was like, all right, I'm gonna try it, man. So I trimmed as much as I could from behind the maxilla, and I just set that maxilla back. So seemingly, it looks like she had a decent mandible advancement, but your eyes are fooling you. I actually set her maxilla back more than I actually advanced her mandible, and then I impacted everything. I brought her maxilla up. So as you can see, she doesn't look so prominent now there, right? Do you see that? How prominent that like area, and then that's her after surgery, less prominent. I actually brought that maxilla back. And then, yeah, through some trickery, I brought the chin forward. Yeah. So